Hello everyone, welcome back. This is Dr Ranjith here again, your pathology educator at Unacademy. So here we are to discuss one more pathology nugget. Pathology nuggets are case series for postgraduates which might help you in diagnosing cases in your routine reporting during your post-graduation time. Might also be useful come handy to revise a topic whenever you want to diagnose something outside your postgraduate time as well. And it might help you in your exam as well. So we have started an entire series of discussions for postgraduate, aiming at postgraduate education at Unacademy. So all of them will be special classes, and the utility of special classes, as you can see them live, interact. You have any doubts, you can clarify them instantly. And if you miss, you'll have it recorded, which you can see at your own disposal. And there'll be lecture notes available. All the PDF, whatever I write, the images, IHC, everything will be there with you in the soft copy in the app, which you can download and use it for later references. And all of them are free for your thing, right? So I urge you, if you're a postgraduate, to attend these special classes. We have finished endometrium and cervix. Hopefully we'll be starting with ovary soon. And once we finish FGT, I'm planning to release a quick booklet for you to revise it, and I need your help in that. Plus you'll have tiny tests to test knowledge. Fine. So join us in the discussion in the Unacademy app, and open your juniors and seniors as well. Fine. So now let's go to our question today. So today case discussion is going to be rather than saying a single case, we'll have an entire group of discussion here based on the single case, right? It's a 25-year-old with a breast lesion. I will go to images. There are 4 sets of images. I'll go to one by one images, then we'll see how to explain the image, describe the image, and let's come to the diagnosis. See, this is the first image here. This is a scanner view image for sure. But one thing I can say this neoplasm is fairly restricted, right? This might be the surrounding breast parenchyma, ductules in the stroma. It is not infiltrating, that's what I mean to say. It is fairly defined circumscribed lesion, but I'm pretty much sure this is very, very solid, right? I don't have any lumen. I do have lumen, but it's fairly solid, at least in this power. Most likely a neoplastic lesion, but let's go to higher power and then make a decision, maybe or not, right? So if we go higher, again I can see those slender capillary network here, see here, okay, and a beautiful capillary network, right? There are lots and lots of capillary network in this area, surrounded by tumor cells. So when I have a vessel surrounded by tumor cells, I'm going to call it a papillae, right? It could be a papillae. Maybe let's go to a little bit higher power and confirm our the 10x again. What I can see here is again lots and lots of tumor cells here. To my surprise, what I see here is I do see few areas which I can call them vessels, right? Though it's a 10x image, I can appreciate the thin extended vessels here, right? So I do have something in my mind as a differential diagnosis. Let's go to a little bit of a higher power and see whether whatever we think is correct thought process is absolutely, it's a tiny bit of vessel here surrounded by layering of tumor cells. It is undoubtedly a papillae right here. Again, perfect papillae, the cut surface of the papillae, right? If you look at this closely, yes, it looks like a perfect papillae, right? So I do have a papillary lesion in the breast, right? So it is completely encapsulated. It is a solid thing. So my first histopathological diagnosis here is going to be a solid papillary tumor of breast. I'm not saying it's carcinoma or benign. I just said it's a solid encapsulated papillary lesion of the breast. When you are going to encounter any papillary lesion in your practice, I want you to report it like this only. Papillary lesion of breast, I require IHC to further categorize them. Even though if you're confident of a benign lesion or a malignant lesion, I want you to do an IHC and then try to report it. It's not to tell you are inferior in histomorphology, it's to have an evidence for my diagnosis. I'll be perfectly correct with an evidence, right? Because when I come to papillary lesions of breast, I have an intra-ID for intraductal papilloma with a TCAS component, which means it's going to change the stage of the tumor, right? And a papillary DCAS alone. And I have 3 papillary carcinoma. One is encapsulated papillary carcinoma, other one is solid papillary carcinoma. The slide which we saw was a solid papillary carcinoma. And then I have invasive papillary carcinoma as well. So I have 6 different papillary lesions, and there is something called microcystic that we'll see later, right? Or inverted papillary. So when I have 6 different papillary lesions, it's difficult for me to go on the histomorphology and to diagnose and to come to a conclusion. I'll tell you how to identify them on histomorphology, how to suspect what type of lesion it is, but undoubtedly you will need IHC to prove this is either one of the 6 category, right? So what are the IHC we are going to use is these IHCs. ME, this is E, ME for myoepithelial marker and E for my epithelium. For the epithelium, only one marker I'm going to use is ERPR. This I'm sure you must have read even during your hyperplasia versus DCAS. In an hyperplastic non-clonal proliferation, I will have heterogeneous positivity of ER and PR. That's what happens. But when it becomes clonal, let it be benign or malignant, it's clonal proliferation, especially in DCS and in your carcinomas. When it's a clonal proliferation, my ER and PR becomes extremely strong. That's for the epithelium, right? So that's very, very helpful for you to differentiate. When you look at the myoepithelium, I have divided them to 2 sets of markers because the HMW is high molecular weight cytokeratins. This cytokeratins, it's unique. It can stain my myoepithelial layer as well as it can stain my epithelial layer as well. So it's like a dual thing for me to come to the diagnosis. But P63 and MHC for myosin heavy chain, right? So those are purely a myoepithelial marker which will not impinge on my epithelial layer. So if you want to go with one marker study to understand the pathogenesis, what type of lesion it is, I would say CK5/6, the best bet you have. But personal experience, I love this marker, myosin heavy chain and ERPR. Personally, when I'm going to have, I use myosin heavy chain, I use ERPR for almost every case of, if I want to report a DCAS, I still apply them. And I'll be more comfortable. Say I will write it's DCAS, but I'll do an IHC, I'll confirm, I'll give it to the surgeon, he or she, right? Whatever it is. Like, so I'm giving a proof that whatever I diagnose is correct. Why I'm saying you also do the same is, undoubtedly these tumors are going to go for second opinion. When they see your report, any pathologist in the world will say, okay, every workup is done. See, in UK and US, every report goes with IHC. Doesn't mean that the CAP protocol does IHC. Doesn't mean that your Memorial Sloan Cancer Center is, they are not comfortable with histomorphology. IHC is the evidence. So I want you to come out of the bubble saying that applying IHC is going to make me inferior, right? There's an evidence. I want you to apply judicially. Not just say, okay, I'm having some doubt of carcinoma, do everything like CK, Wyminton, KS6 and everything. No. That I need to know the histomorphology, and I'm going to say use the markers. I know what I'm going to see. With that permutation combination, I'll say this is the possible diagnosis, right? So now look at each of the 6 entities the microscopy, histopathology and my IHC as well. Before that, we need to understand a few terms. The first thing I'm going to compare is intraductal papilloma and my papillary DCS, right? In between entity was my papilloma with DCS, which will have both of them. See, papillomas will have a broad-based papillae. When I say a broad-based, you will have a very, very thick fibrovascular core and it will be blunt like this. What we saw in this lesion, our case was, papillae is like this, right? It was tapering. It was slender going like this. We had vessels like this, right? It was like this. So when you have a slender papillae, tapering papillae, I generally think it is a neo-malignant process, or at least in the side of malignancy, at least DCAS. When I'm having a broad-based papillae, I'm going to comfortable to call it an papilloma. So histomorphology, so I know to differentiate them, right? I'm not saying I don't know. I know, but I'll apply markers still. So when I say papilloma with DCS, these are the entities which are much worrying for me. That's one reason I need to apply your IHC. See, when I say papilloma with DCS, the second entity, I'll have maybe in this entire lesion, half of them or 3/4 of them papilloma. Maybe in this tiny area, I'll have DCS foci. So there is more chance for me to miss it if I do just in histomorphology, right? Still, you can pick them up. I'm not saying you're going to miss. You'll pick them up for sure to prove, or someone else not accept that is in DCS, right? So to prove, I'm going to use an IHC, right? So I know about papilloma. I need to know about my epithelial and the myoepithelial component. When I take an benign lesion, intraductal papilloma, my epithelial component here, which is lining the papilloma, will be totally heterogeneous, not pleomorphic. Heterogeneous in the sense I'll have 2 or 3 groups of cells. They'll be uniform. One group of cells will be bigger, other group of cells will be smaller. That's one thing for me to say, okay, it is towards benignity. And when I'm going to look at a DCAS component or maybe a malignancy, it will be monotonous. almost everything looks the same, right? That's with the epithelial component. So when I take my myoepithelial component, again when you apply IHC as well as when you're going to look at the histomorphology, I want you to look at myoepithelial component in two different aspects. That's very important. I'll tell both the aspects, then that will easily help us to identify your IHC, to understand about IHC, right? This is the thing. See, I had a papillae and have a lesion like this. Like this outer blue thing is the entire lesion. Like we saw, we had an encapsulated lesion, right? That's what we saw. And the other one is inside them they were papillae. So which means this entire papillae is also a TDL use component, right? So am I right in saying that this papillae also will have myoepithelial cells? Yes, they will. So that's one. So those are called as papillary myoepithelial cells, right? So papillae will have epithelial, will have myoepithelial if it is benign. Papillae will have only epithelial if it is malignant, no myoepithelial, right? Perfect. So on the other hand, the outside lesion also I should look at the myoepithelial layer. See, it's what's happening here is let's assume this is a TDLU, a terminal lobule. Inside this, I have my epithelial cells like this, and this epithelial cell is going to become like a papillae, right? This epithelial kind of becomes like a papillae. This epithelial cell kind of becomes like a papillae. That's how it grows, right? So what I'm saying is this lobule will have one layer of myoepithelial cell, and also this papillae also will have layers of myoepithelial cell. I have to look at both. In a benign papilloma, both will be present. In a DCAS, which you think will be present? DCAS is there's no stromal invasion, right? So which means your peripheral myoepithelial cells alone will be present, but my papillary myoepithelial cells will be gone in a DCAS. But in a cancer, everything will be gone. See, I know the gradation here. Normal papilloma, everywhere is present. DCAS, surrounding alone gone, and cancer, everything is gone. Got it? That's my transition here. So if I'm going to look at the carcinomas, see, carcinomas had invasive papillary carcinoma, which is simple, like my IDC, but I'll have invasion in the stroma, which is on the form of a papillary architecture. That's all. When I go to solid papillary and encapsulated papillary, in an encapsulated papillary, inside I will have papillary lesions, proper papillae, but with a perfect capsule. In a solid papillary, our case was a solid papillary, that also will be encapsulated only, right? It's not going to invade. So solid papillary, I'll have solid tumor cells, maybe like back to back arranged papillae. So that's the difference between an encapsulated papillary and a solid papillary. I do have IHC difference as well, fine. So I'm sure you're clear with histomorphology. What I'm going to look is, first look at the papillae, broad base or slender. Second, look at the cells, epithelial, monotonous or heterogeneous. Third, look at the myoepithelial cells. When you look at the myoepithelial cells, look at both my papillary myoepithelium and my periphery myoepithelium. These are three places I'm going to look in histomorphology. Then look at the beauty of IHC. IHC will make sure everything is perfect and clear for me. Again, as I say, when I say myoepithelial marker, I am mentioning your P63 annulomyosin heavy chain. When I say CK, it's generally CK5R6 or CK14, which will be positive in both my myoepithelial cell as well as in my epithelial cell, right? When I say ER, I'm going to look for only in my epithelial morphology. Got it? Fine. So when I take an intraductal papilloma, myoepithelial cell, when I said in the papillary and the periphery, both the places. In both the places, it will be positive. Obviously, it has to be positive, right? When I look at the cytokeratin, CK5R6 will be positive and ER will be heterogeneous. When I say heterogeneous, it is undoubtedly your usual ductal hyperplasia type and is benign proliferation, that's all. If you have in your papillary lesion apocrine metaplasia, in apocrine metaplasia ER will be negative, and I want you to know that, fine. Please keep in mind ER will be negative in an apocrine metaplasia, got it? When I say papilloma with DCAS, I'm going to have both the things here, right? Which means in your papillae, the papilloma type of papillae, both will be present. But in the DCAS component, my cytokeratin is going to be negative. When I say cytokeratin negative, I'm going to talk about the epithelial cytokeratin, not my myoepithelial, right? All of these are my epithelial cytokeratin. When I say myoepithelial, it will be the same, right? In the myoepithelial cell, the expression is going to be same like my papillary and periphery myoepithelial cell. These all are epithelial cytokeratin. And it's in the DCAS foci, ERPR is going to be strong. But in the surrounding background heterogeneous population of the papilloma, ERPR will be heterogeneous only. That makes me very confirmative. I have a big lesion here. In this place alone, I'm having your strong ER positivity. Then I want you to go back and look at the histomorphology. Does it match? Monotonous, strong ER positivity, DCAS. You have to match and you have to look at what place you're going to look for myopathy cells. Marking and looking in IHC is a technique which you should excel, everyone should excel. I'm having such a big lesion, even doing IHC also, say I want only in this area. Mark this, give to the technician, make sure they don't miss that area. Because when you have a big slide, you might miss it. The marker will not float in the area. If the marker doesn't reach my area, my entire diagnosis is gone, right? So mark, I want to look at this only. Again, for that you should be strong in histopathology, right? Then you do an ISC and interpret it, right? In a papillary DCS, the papillae myopathy will be absent, but it's DCS, so the peripheral lobe will be present. ER, PR will be strong and cytokeratin will be negative, and as I said, this is for epithelial cytokeratin. Every carcinoma, all over myopathy cell is going to be absent, ER is going to be strong. When I say solid, like in our case, there might be again heterogeneous expression of myopathy cells. That's how it is. That's how the WHO explains them. That's how it will look. Don't think them they are benign. It will be patchy here and there. So solid papillary carcinomas will have a patchy expression, maybe sometimes completely negative. But what tells me it is still malignancy is a complete pitch dark negativity for my cytokeratin 5 or 6 and extremely strong ER positivity. Actually, there's something called S written here, right? My video's hiding that. So this solid encapsulated papillary carcinomas are generally will have a neuroendocrine differentiation. So neuroendocrine differentiation, do a synaptophysin if you doubt, or even otherwise do a synaptophysin. I am not having the marker profile for our case. I didn't have the slides. I had only the histomorphology with me. But if you have a solid papillary carcinomas, I want you to do one synaptophysin. Invasive is straightforward. Everything is going to be negative and here is going to be completely strong positive. And you can appreciate the invasion on my histology itself. Fine? Clear? Got it? I'll show you one case from WHO. Those images, what I'm going to show, both the image sets are from WHO. The first image will have both histology, IHC, as well as the second image will have only histology, right? The first one was encapsulated, right? I want you to understand and know the difference. This is an encapsulated lesion for sure with a capsule. The next one is going to be solid. So this here is my cytokeratin 5/6. See, this is my periphery of the lesion. Are you seeing cytokeratin 5/6? Absent. So it is not DCAS. If it was DCAS, the periphery will be positive. In the papillary, are you seeing any cytokeratin 5/6 here? No, right? So it's negative in the papillary fronts. This is where I look for cytokeratin. If it is cytokeratin 5/6, CK 5/6, if it is positive. And this is where I look for CK positivity if it is DCAS. I hope you are clear now. In an intraductal papilloma, if this is intraductal papilloma, it will be positive here as well as it will be positive here. Got it? I'll use a red color marker to say how it will be in DCS. In a DCS, it will be negative here, but it will be positive here. The periphery will be positive. In a papillary carcinoma, like here, both of them are negative. Perfect. And the third marker here is ER. It's perfect, right? It's completely positive. It will have your classical positivity of 5+2, 5+3. The classical ER positivity will be there completely, and strong and diffuse positivity says it is neoplastic. Fine. So this is how your encapsulated papillary carcinoma will look. The difference between this and your solid papillary is the architecture. See, it is solid. It's undoubtedly solid, right? On a low power, I cannot appreciate a papillae. That's what our case was. On a low power, I was not able to appreciate the papillae, right? I hope it is clear now. Fine. Papillary lesions of breast is a very, very important topic for a postgraduate. I want you to excel it. Next time you have it, you're going to tell to your assistant professor or professor who you're reporting with, sir, I need IHC. I'll diagnose with 100% certainty. There are 6 lesions, just 6 lesions. 3 markers enough for me. If you are going to save, do 1 marker, CK5/6. That will tell me what's happening here. But if you're doing CK5/6, be very careful to interpret the epithelial and the myoepithelial component separately. Don't confuse them. Got it? Okay, I hope it is clear. If you have any doubts, do comment below. And I want you to, if you're a postgraduate, follow me in the Unacademy profile. And there'll be lots of classes for you, which will be free. And all of them will be special classes. And let's try and complete pathology completely, right? Hopefully you enjoyed the session of the papillary lesions of breast. See you soon with another topic. Till then, bye-bye from Dr. Ranjith. Thank you and bye-bye. If you have any doubts, again, please do comment below and let's trash all the doubts and let's diagnose with certainty and more confidence. Fine. Thank you guys. Bye-bye.